Welcome to GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.
Haematology, Oncology. Think A to G. Our specialist is Dr. Suzanne Roberts, consultant haematologist. A. Acute leukemia.
Acute leukemia is one of our most serious blood cancers, but actually patients can present in one of two extreme ways. The first way they can present is actually just through a routine blood test, where the patient currently feels completely well. They've usually gone to see their GP for annual checkup or a blood pressure check, something like that. They've happened to have a full blood count performed. And then on that sample, we're able to see in the haematology laboratory at the hospital that there's a problem with the blood. That obviously comes as a huge shock to patients when they're presenting that way. The other way patients present can be as an emergency. Sometimes they come directly to A&E having bypassed primary care, or other times they're phoning up saying that they feel unwell. And that can either be with symptoms of anemia, so becoming progressively more tired and short of breath and run down. It can be with fevers, either because they're starting to brew an infection due to low white cells, or because of the disease process itself, which can cause us swinging pyrexias. The other symptom we sometimes see is the easy bruising or that non-blanching petechial rash that we can see with the low platelets. Not all patients will have all of those features. Some will have one or two or all of them. And like I said, some patients actually are completely well and asymptomatic at the time.
B. Bumps and lumps.
Lymphoma is, generally speaking, a lumpy disease. These are the patients who present with the enlarged lymph glands. That could be in the neck, in the armpits, or in the groin. There will also be patients who present with lumps inside the chest, which will cause symptoms such as chronic coughs, shortness of breath or chest pain. And then there'll be the patients with the large lumps inside the abdomens. So those patients might present with weight loss. They may have abdominal pain, poor appetite. We also discuss what we call the B symptoms of lymphoma. These are weight loss of more than 10%, and the drenching night sweats.
C. Chronic leukemia.
Again, most of these patients will present asymptomatically on a routine blood test. And quite often, if you look back over the last year or two in someone who's having regular blood tests, you can see a slightly abnormal lymphocyte count that's progressively going up over time. That's the most common way a patient would come to us, is with just a blood test finding, or they may present with a lump they felt at home. Patients with lumps, I think lumps will come on a 2-week pathway. I think that's important. We don't know it's chronic lymphocytic leukemia rather than a more serious lymphoma without further diagnostic testing. So lumps always on a 2-week pathway. Slightly abnormal blood test results can come in routinely. A very high lymphocyte count, and for that I'd say anything more than 10 should come on a 2-week pathway, because we don't know it's a chronic lymphocytic leukemia that can be monitored without further testing. It could be another type of lymphoma.
D. Don't forget myeloma.
Myeloma obviously causes those diagnostic criteria which we refer to as CRAB. So hypercalcemia, renal impairment, anemia, bone disease and bone problems. So the way we sometimes get our patients for myeloma is patients with back pains, which I know is obviously another very common symptom out there in primary care. Lots of patients will come with musculoskeletal back pain. When do we investigate further for myeloma is quite a challenge. New renal impairment or worsening chronic renal impairment should always prompt to screen for myeloma, as should a new anemia, particularly if it is macrocytic. So anemia due to myeloma is very, very commonly macrocytic in our experience.
E. Examination and blood tests.
So there is a blood test now that's mostly replaced Bence-Jones protein in the urine, and this is a test called serum free light chains. Now this is available to order from primary care and should be in all the areas of Greater Manchester. It is within the NICE guidelines. There is a slight issue with interpreting it, and we understand that and we are sympathetic. It is affected by things like renal impairment, and obviously what is a little bit abnormal and very abnormal, if you've got no experience with this, can be difficult to judge. And that's where I'd recommend that you use the advice and guidance service if you've got that available to you with your local trust, just to ask for some help with interpretation if you're stuck. A full blood count's helpful for us in the sense that it will show us leukemias. It will show us if the lymphoma is causing problems in the blood, like anemia, which would be the main issue we'd see, We can also see some other reactive processes in the blood, occasionally a high platelet count. But no, a full blood count is essential for acute leukemias and chronic leukemias, but of little diagnostic help in lymphomas. There is a lot of utility in ultrasound scanning. We can see the characteristics of the lymph gland, in particular whether the fatty hilum is preserved. And our radiology consultants will be very confident in saying this is a reactive gland, nothing to worry about, versus this could be a potentially malignant gland and needs a biopsy.
F. Family history.
So for a very anxious patient who thinks they can feel something, if you're examining the patient and you honestly think to yourself, I just can't feel this lump this patient's so worried about, that is when these scans are very helpful. And I will honestly, I refer a lot of patients for reassuring ultrasound scans, to be honest, where the patient's very worried about something, either they've got a family history or some other reason to be anxious, they're convinced they can feel a lump. I really think what they're feeling is normal structures, either in the neck or the axilla, in which case an ultrasound scan showing an absence of any worrying lumps is usually enough. It's obviously there's no radiation involved in that, and it's very important for the patient to have had that diagnostic investigation performed.
G. Greater Manchester Referral Proforma.
The only way to diagnose lymphoma is with a biopsy, so we need to make sure these patients get to the right place for a biopsy as quickly as possible, and that is with the surgical services. So in terms of the neck lumps, they should all be going to the neck lump clinic. There's very nice, clear, one-stop shop clinics for neck lumps nowadays in all trusts. That is the referral pathway we need. If a patient has come to see their GP with a neck lump and you've examined and you think it's a lymph gland and you're worried about lymphoma, if they come and see me first, all I can do is agree with you and send them on to ENT. I can't do anything from my clinic to move their patient pathway along. All I can do is refer them to ENT and say, I have a patient with a neck lump, can you get a biopsy please? So all we're actually doing there is adding an extra step in the patient pathway. We have really good relationships within all the trusts between haematology and the other surgical specialities like ENT. We also get referrals through the lung pathway, through colorectal. So it's important to get the patients to the right place for the biopsy. Neck lumps is ENT. Lumps in the axilla is to the breast team. So they should all go straight to the breast services for their scans and biopsies. Lumps in the groin is a little bit controversial between trusts. Nowadays, they should all really be going through the RDCs, those rapid diagnostic centres. It is part of their referral criteria. In the past, they used to come in through the general surgeons, and if you're unsure as to the nature of the lump, that's still probably the right pathway. But again, if they come straight to haematology, all I can do is refer them on for biopsy. So they shouldn't be coming directly to haematology, but rather to the place where they need the biopsy.
Think A to G. A. Acute leukemia. B. Bumps and lumps. C. Chronic leukemia. D. Don't forget myeloma. E. Examination and blood tests. F. Family history. G. Greater Manchester Referral Proforma.
GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.